Good evening, everyone. Welcome once again to DTech Dialogues. You know, this has been a great endeavor, not because of what we present alone, but it's also because of all of you participating in it. And we are so thankful for all of you to join in. Every time we give you a shout out that, yes, we are ready with the next DTech Dialogue. And as you can tell, it's a dialogue, and we want your feedback. We want your questions. We have a wonderful panel discussion. And before that, we have an even more wonderful talk by one of our international speakers. And I am just so in anticipation of this evening because it's a wonderful topic and something that we all could understand more about and learn about, leveraging CGM in pregnancy. So with that, I invite one of our founder members of DTech, Dr. Manoj Chawla, to introduce our speaker.
Evening, everyone. Thanks, Purvi. It gives me great pleasure to introduce an old friend, a dear friend, Professor Nick Oliver. Thanks for joining us, Nick. Professor Oliver is a clinical director for specialist medicine at the Imperial College Healthcare NHS Trust in UK. He's a type 1 and diabetes technology clinician delivering care at the Imperial College NHS Trust, one of the largest hospital groups in the UK. He's developed a center of excellence for type 1 care and has established the insulin pump, CGM, and intraperitoneal insulin services. Dr. Oliver is well published and he has worked in various roles across the UK. He's currently a senior diabetes clinician and researcher who heads a multidisciplinary cross-faculty translational research group at Imperial College and has established a research facility that any of us in the world would envy. So with these few words of introduction, let me welcome Professor Nick Oliver for today's conversation. And once again, from the entire group of DTech, all the founders, welcome here today, Nick, and we look forward to learning and listening from you. Thank you.
Thank you so much for inviting me. It's an honor to be here. What I didn't ask is if I need to share my slides or if you will do that for me.
I can do that for you.
Whatever you would prefer, Nick.
Okay, I can do that, no problem. So hopefully you can all see my slides.
Yes, now we can.
Fantastic. So good afternoon from London. Good evening to you all. So it's a pleasure to be invited by old friends and lovely to see you all. I may have seen some of you in July when I was in Chennai, and hopefully next time in India I get to see some of you again. So it's my pleasure to talk tonight about how technology solutions can transform diabetes care and pregnancy. As my introduction has already said, I mostly look after people with type 1 diabetes, and my clinical research is into how we can apply technologies for people living with diabetes in a way that's safe and effective and acceptable, because diabetes is a lifelong condition and can be very challenging to live with. Diabetes in pregnancy is particularly important, as you will all know, and I will talk through a little bit of the diabetes technology evidence base for care in pregnancy for women living with diabetes. So these are my declarations of interest. So the things that I'm going to talk about, I'll talk briefly about pregnancy and type 1 diabetes. I'll talk about continuous glucose monitoring, effectiveness, cost effectiveness. We'll think about women at highest risk of hypoglycemia, and we'll think about it in context of insulin pump and multiple dose injection regimens in type 1 diabetes. I'll talk briefly about hybrid closed loop insulin delivery technology in type 1 diabetes, and then I'll talk about pregnancy complicated by type 2 diabetes, and I'll offer some thoughts about gestational diabetes, and I'm sure there'll be a lively panel discussion afterwards. So these are data from London, from what's called the National Diabetes Audit that happens in the United Kingdom, the London NDA data. And these go back a few years between 2021, towards the end of COVID lockdowns, into 2023. And our data are two things, I think. Our data are really robust and well reported and accurate, and we collect data on almost every pregnant woman with diabetes. But the other thing the data are is that they tell us that we still need to do lots of work and that there are still areas where we need to improve. So in London, over that 2-year period, nearly 20% of women with type 1 diabetes didn't present to the joint diabetes antenatal team before 10 weeks of gestation. So that opportunity for early advice, support, optimization, and medication was missed. And what that means is that we're unable to start folic acid if women aren't already on it. We're unable to give them conception counselling about what to expect during a type 1 diabetes pregnancy. And we're unable to start the process of optimizing glucose. And of course, by 10 weeks, you're more than halfway through the period of organogenesis of pregnancy. Organogenesis is generally finished around 16 to 18 weeks. And it's that critical phase where anomalies may accrue if glucose isn't optimized. And 1 in 5 women miss that opportunity. 40% of babies born to women with type 1 diabetes were large for gestational age, and preterm delivery occurred in roughly the same number of singleton live births. So we have a large proportion of women with large babies, a large proportion of women having preterm delivery, and over a third of those deliveries are admitted to neonatal care. Sorry, that should be neonatal intensive care, and only around a third of women have an HbA1c that is within target, less than 6.5% in early pregnancy. So these are great data. They're really helpful to tell us what we still have to do, but they're also not great news, and that there are a significant number of women and therefore babies who are at risk from type 1 diabetes pregnancies. As you all know, type 1 diabetes has significant risk, and the most important thing we can do is achieve target HbA1c throughout pregnancy. These are data from last decade, actually published in Diabetologia, and the black is type 1 diabetes and the grey bars are type 2 diabetes, and it tells you the percentages of birth to women with target HbA1cs at 13 and 24 weeks, or before 13 weeks and after 24 weeks, and above target throughout both of those periods. And it tells you a familiar story that despite our interventions and our best intentions, a reasonable proportion of women are above target HbA1c at 13 and 24 weeks, and 48, that's around a half of women with type 1 diabetes and over a third of women with type 2 diabetes. So while the London data are more recent, this is a larger problem and is not significantly changing. And of course, you're all familiar with this as well, that the stillbirth rate, the dotted line across there, is the stillbirth rate for the general maternity population. And those are two different data sets, the National Pregnancy and Diabetes and CMAC data sets. And they both show that women living with type 1 diabetes have a really significantly elevated risk of stillbirth, which is enormously distressing for everyone involved. So we still have a lot of work to do here. Optimal glucose is critical to outcomes, and we all acknowledge that it can be challenging and complicated by extremes of glucose, and we know that education and support are paramount, as well as regular visits to the antenatal clinic and the joint antenatal obstetric service. But the question is, can technologies help to achieve more optimal glucose for materno-fetal outcomes? So continuous glucose monitors sample the interstitial fluid and have a needle type enzyme based electrode. So there's a small needle sits under the skin that has glucose oxidase attached to it, and they sense glucose in real time, and they transmit that glucose information usually to a smartphone or a receiver. And the smartphone or receiver can tell you the concentration of glucose, but also the rate and direction of change, and can give you alerts and alarms for high and low glucose in real time, and can prompt actions appropriately. We know from lots of other evidence base and from lots of other clinical studies that continuous glucose monitoring for people with type 1 diabetes reduces HbA1c significantly, increases the time spent in the glucose target range, reduces exposure to hypoglycemia, and very importantly, reduces the incidence of severe hypoglycemia. And whenever I talk about severe hypoglycemia in this context, by the way, I'm talking about episodes of hypoglycemia that require the assistance of a third party for active treatment. So those are the ones that require a partner or a friend to treat, or require an attendance to the emergency department or an ambulance attendance. Continuous glucose monitoring reduces glucose variability, positively impacts most person-reported outcomes, and we know that its effectiveness is independent of insulin modality. So you get the same benefit if you use multiple dose injections or if you use an insulin pump. And in the real world, we know that continuous glucose monitoring can reduce hospital admissions and work absenteeism, and continuous glucose monitoring is now, I think, standard of care for people living with type 1 diabetes where available. So what happens in type 1 diabetes pregnancy? Well, the concept study is the landmark study that tells us about the effectiveness of continuous glucose monitoring for women living with type 1 diabetes who are pregnant. It was led by Helen Murphy and colleagues and is a multi-center open-label randomized controlled trial of women aged 18 to 40 who have lived with type 1 diabetes for a minimum of 12 months and are on an intensive insulin therapy regimen, so use insulin injections more than twice a day or an insulin pump. And they recruited either pregnant women before 13 weeks of gestation or those women planning pregnancy. They were randomized to continuous glucose monitoring or self-monitored blood glucose, which was the standard of care at the time, and the primary outcome of the study was the change in HbA1c. So this tells you a little bit about the population and the flow of the study. I think the thing to focus on here is that the women were around 30 years of age. They were predominantly white European, and they were recruited at about 10 weeks of pregnancy. Around a third of them, or slightly more, were primates, so in their first pregnancy. And as is true of almost all type 1 diabetes studies in white European people, the median BMI was slightly above normal. So in general, in studies, people with type 1 diabetes appear now to be on average overweight. And they'd had a duration of diabetes that approached 20 years. As I highlighted earlier from our own data, the percentage of HbA1c at enrolment was above target for pregnancy. Excuse me. But at enrolment, that is, but at randomization had fallen, which is encouraging. I'm still astonished that 12% of pregnant people smoke. 12% of pregnant people with type 1 diabetes smoke. But that is the number, and only a half of those women were on preconception folic acid. So we still have a lot to do in terms of preconception counselling. Around a half of this population used insulin pumps. So this is what happened to HbA1c in the concept study. And if you look on the left-hand side, those are the women who were pregnant. The middle graph is those who were planning pregnancy, and those on the right are those who were planning pregnancy and became pregnant. And I think there's a couple of things to notice. The first is that actually, if you were pregnant and you were randomized to continuous glucose monitoring, the difference in HbA1c really only started to appear at 34 weeks. So the lines are very similar through to 24 weeks. There's a slight uptick in HbA1c towards the end of pregnancy, but the lines don't really separate. Again, those who are planning pregnancy do get some advantage, but it doesn't appear until 24 weeks. And the same for those who became pregnant, who were randomized earlier. Obviously, they went into their pregnancy with a slightly lower HbA1c because they'd been randomized to CGM earlier. But again, there are not huge separations of the HbA1c lines. And I think that really tells you how women are desperate to have the best possible glycemia they can in pregnancy, and it's therefore difficult to drive additional differences in HbA1c. But it's important to remember that those changes only really start to appear towards the end of the pregnancy. So the between group difference in the primary outcome of HbA1c was clinically not massive. It was 0.2%. And if you offered most people a reduction in HbA1c by 0.2, they would, of course, take it. But that might be felt to be clinically not the most important drop in HbA1c. And as I said, it only really appeared towards the end of pregnancy. The study did meet its primary outcome, but I think everyone felt that that was not necessarily an enormous reduction in HbA1c. And were it not for the other data that came out of that study, it may have been felt to be statistically but not clinically hugely important. But this is the data that is really, really important, because these are the additional neonatal outcomes from using continuous glucose monitoring in pregnancy affected by type 1 diabetes. So there was a clinically meaningful and statistically significant reduction in large for gestational age babies from 69% to 53%. The percentage of babies with neonatal hypoglycemia requiring IV dextrose fell by half, essentially, from 28% to 15%. Those requiring high-level neonatal intensive care fell from 43% to 27%, and the infant length of hospital stay in days fell from 4 days to 3 days. And if we look at that as a numbers needed to treat, this is a fairly astonishing slide, because you can give 6 pregnant women CGM to prevent 1 neonatal intensive care admission, 6 pregnant women CGM to prevent 1 large for gestational age baby, and 8 pregnant women CGM to prevent 1 case of neonatal hypoglycemia. So these numbers needed to treat are tiny. And when you compare the numbers needed to treat for things like statins, these are much lower. And we were very fortunate in that from 2020, shortly after this was published, all pregnant women with type 1 diabetes have been offered CGM as part of routine care. And hopefully now it's standard care preconceptually, and all women should enter pregnancy already established on real-time continuous glucose monitoring. Not only is it very clinically effective, it's also very cost effective. So this is a cost effectiveness analysis of the same data from the concept study. And it shows very nicely on the left there that the cost of CGM is around cost with CGM, per year is around £15 million. But it's closer to £25 million with self-monitored blood glucose. And the massive majority of that cost accrues from the large grey blob in the middle, which is neonatal intensive care admission. So by reducing neonatal intensive care admission, there's a £9.5 million annual saving in England from using CGM routinely in type 1 diabetes pregnancies. We have a dashboard that we're able to look at that collects data from the National Diabetes Audit that tells us our type 1 diabetes pregnancy data. Excuse me. And these are data from that same period I talked about earlier, from 2021 to 2023. And you can see, if I point you to sort of the right-hand side where it says percentage of CGM offered and percentage of CGM accepted. And bear in mind, this is shortly after implementation of continuous glucose monitoring. And you can see that around a third of women were already on CGM in pregnancy, half of them were offered CGM, and 15% weren't offered CGM. But out of those that are offered, there's around an 86% acceptance rate. And actually, that increased over time to much closer to 98 or 100%. And you can see the differences in real world data in the blue and green bars below. Blue is with CGM and green is not on CGM at 28 weeks. And you can see that there are improved HbA1c outcomes with CGM. There are reduced numbers of deliveries admitted to neonatal care with CGM, fewer preterm babies, fewer SGA, more babies average for gestational age, and fewer LGA. So this is a very nice dashboard that tells us that the data that were in a randomized controlled trial are translated across into the real world. And it would be very nice to see some more recent data, and I'm sure that will come in due course. So I should just say about the glucose targets in type 1 diabetes pregnancy. If you do use continuous glucose monitoring, they are different to the times in ranges outside of pregnancy. And we define time in range as 3.5 to 7.8 millimoles per litre. Time above range is greater than 7.8. Time below range is below 3.5. And the numbers are roughly the same. 70% in range is the target. There's a little bit of early education to do here with women who are pregnant, because they have been taught often for many years that 4 is the floor. And any value below 4 millimoles per litre should be treated as hypoglycemia, and trying to encourage women to sit with a glucose between 3.5 and 4 can sometimes be challenging. So, milligrams per deciliter, that's between 63 and 70. So we're trying to encourage women to sit in that range, and that can feel very uncomfortable for them, not because it's dangerous, but because they spent their time, their type 1 diabetes career before that, trying to avoid that range and actively treating that range. But that's an important learning point, and an important thing to bear in mind. And it's important to reiterate that education, that a value in the high 60s is not harmful for the pregnant woman or for her baby, and that it's very safe to sit there. And in fact, the optimal outcomes for her baby are sitting in that range. So this is what happens again in the concept study to hypoglycemia. The women were divided into 2 groups, essentially, those with impaired awareness of hypoglycemia, that's the IAH groups on the graph on the left, or normal awareness of hypoglycemia, NAH. And you can see that at baseline, the impaired awareness group had slightly more exposure to hypoglycemia, below target of 63 milligrams per deciliter, whereas once established on CGM, those were the same essentially. So what that tells us is that continuous glucose monitoring was effective in ensuring that women with hypoglycemia impaired awareness did not have significantly greater exposure to hypoglycemia through their pregnancy. And you can see here that actually the normal awareness group had seven women, had an episode of severe hypoglycemia in the year prior to pregnancy, compared to 13 women in the impaired awareness group, which is what you'd expect, an increased incidence of severe hypoglycemia. But then during the study, that was significantly reduced by the use of CGM, and the number of episodes in both groups was significantly reduced, which is obviously incredibly important. So both groups had time below range greater than the consensus target throughout pregnancy, the consensus being 4%, and they were around 5%. Severe hypoglycemia is more common in those women with impaired awareness, but despite CGM with the predictive alerts meeting those targets without exposure to hypoglycemia is challenging, and that's an important learning point, that outside of pregnancy, we know that hypoglycemia exposure is reduced with real-time continuous glucose monitoring, but when aiming really tightly, there is an inevitable increase in exposure. But the important thing is to render women as safe as possible. So the other thing that I said about continuous glucose monitoring outside of pregnancy is that its clinical effectiveness is independent of insulin delivery modality. So it doesn't matter if you're on an insulin pump or a multiple dose injection regimen, you get the same benefit. And this is looking at the pump and the MDI group in the concept study. You'll remember I said that it was roughly 50-50, 50% were on an insulin pump, 50% had MDI. And you can see that at randomization, the HbA1cs were the same. But then in the second trimester, actually, the MDI group had a statistically significantly lower HbA1c at 24 weeks. And that was maintained, a lower HbA1c in the group of women using a multiple dose injection regimen compared to an insulin pump. And that was true both as the absolute value and as the change from randomization to 34 weeks. And this, I think, when you initially look at it, is a surprising finding. We tend to associate insulin pump therapy with tighter overall glucose and glucose closer to target. But in pregnancy, in the concept study, the multiple dose injection group had the lower overall HbA1c. And even more interestingly, when we look at how that converts to those materno-fetal outcomes that we talked about, both high-level NICU care and neonatal hypoglycemia were lower in the multiple dose injection group compared to the insulin pump group, and that goes with, as you would understand, that would go with the overall improvement in glucose. But nonetheless, it's surprising that the majority of the clinical benefit that we saw in concept and those materno-fetal outcomes that were very cost and clinically effective, the majority of that was accrued in women on a multiple dose injection regimen. So these are, as I say, perhaps surprising results. There is, though, the selection bias of insulin pump users pre-gestation. So those women who were put on a pump may have had a greater frequency and severity of hypoglycemia at baseline, or may have been unable to achieve their target HbA1c, which is the established NICE guidance for insulin pumps at that time. And the other thing that I think is often true is that there is less insulin pump dose adjustment in women than there would be in multiple dose injection regimens, because there's some unfamiliarity in our joint antenatal clinics, certainly amongst obstetricians and midwives, who are unable to make adjustments to insulin pump settings. So there may be slower intensification with insulin pump compared to with a multiple dose injection regimen. But I think it's very reassuring that you can take a basal bolus regimen and use a CGM and derive a fantastic benefit, both in terms of glucose and in terms of materno-fetal outcomes. But if it's true that teams are not as keen to intensify insulin regimens when you're on an insulin pump, could it be that automated insulin addresses the hypoglycemia risk and apparent weakness of insulin pump therapy in pregnancy? And of course, that's where the hybrid closed loop insulin delivery systems come in. So the ideal treatment here is to restore normal glucose and insulin physiology, maintaining glucose wholly within the physiological range. And it is, of course, the holy grail of type 1 diabetes management before we get to a cure. So closed loop systems ideally require minimal input from the patient. They avoid hypoglycemia, achieve near normoglycemia, and they exchange the glucose variability that we see when we take 4 or 5 injections a day. They exchange that glucose variability for a dynamic insulin variability. Insulin is varied much more regularly and much more quickly in response to glucose changes. So we hopefully see a flat glucose line and a very movable insulin line rather than the other way around. So this is the ADAPT study, again, led by Helen Murphy. And this is a randomized controlled trial of hybrid closed loop insulin delivery in women with type 1 diabetes in pregnancy. They used the Cambridge, the CAM APS FX system versus standard care, and standard care included women on open loop pump therapy, but 59% were on a multiple dose injection regimen. And they're a similar group to the previous study. They're around 30 years of age. They're predominantly white European. They've had diabetes for nearly 2 decades, and their BMI is slightly into the overweight range. They don't report smoking here, which is good because I don't get it, so I won't get upset about it. These are the percentage time in range with the closed loop and the standard care group throughout pregnancy. The closed loop group is in that slightly orangey brown color, and the standard care group is in blue. And you can see that throughout pregnancy, at every stage where this was assessed, the closed loop group spent more time in the glucose target range than the women in the standard care group. Again, though, it's important to bear in mind that these are the pregnancy targets, so 3.5 to 7.8, so it's much harder to achieve 70%. And it's again important to remember that women throughout pregnancy with type 1 diabetes are striving to achieve glucose closest to target at all times. And usually women will have the best overall glucose of their entire type 1 diabetes career during their pregnancies. If we look at what the glucose looked like on average over a standardized day from midnight through to midnight on the x-axis, you can see that, as we always see with hybrid closed loop insulin delivery, the greatest time spent in target range is overnight, and it increases until shortly before waking, when almost everyone wakes up with a glucose in the target range every morning. So you can see that the graphs really separate the most overnight between 4 a.m. and 8 a.m. And then daytime is generally better, but the confidence intervals do overlap, though the overall average glucose is better with a closed loop than with standard care throughout the day, as well as the larger difference overnight. You can see that the outcomes, excuse me, and maternofetal outcomes, again, there are differences between closed loop and standard care. There's a significant reduction in large gestational age, falling from 50% to 39% with closed loop therapy. There's no difference in hypoglycemia treated with intravenous or oral glucose, around 40% in both groups. And there's very little overall difference in neonatal intensive care stay, 20 to 22 or 25%, or median length of hospital stay. In fact, it looks like it's slightly higher in the closed loop group. So there's differences in maternofetal outcomes that we saw in concept don't seem to be replicated by the addition of a closed loop insulin delivery for women in pregnancy, though there are incremental improvements in overall glucose. And similarly, if we look at severe hypoglycemia, I don't think these are necessarily statistically significant because there are very few events, but there's certainly no difference between the overall incidence per 100 patient years, and you could even argue that there's a slight increase in the closed loop group. So the ADAPT study did show improvements in glycemia throughout pregnancy, mostly achieved overnight. There's a lower frequency of some maternal-fetal outcomes, but not all of them, and there were no changes to NICU admission, readmission, or length of stay, and no impact on severe hypoglycemia compared to usual care. And we don't have cost effectiveness data, but obviously hybrid closed loop systems are the most expensive therapy for type 1 diabetes when taken as an in-year cost rather than as a cost effectiveness calculation. So in terms of budget impact, they are the most expensive way to manage a type 1 diabetes pregnancy. There is a second study of hybrid closed-loop insulin delivery in pregnancy called the Crystal study. So the ADAPT study used the Cambridge system. This uses the Medtronic 780G system, which I think you have in India. So again, this was people or women who are pregnant with type 1 diabetes, but there are some important differences in the study. So the first is that only 4% of this study group used multiple dose injections at baseline compared to more than half in the ADAPT study. There's a similar age, BMI, and diabetes duration though. And this is the time in range, again, the specific pregnancy time in range. And you can see really very little difference between advanced hybrid closed loop therapy and standard insulin therapy. There is a very small separation of time in range at the around 20 to 23 weeks. But beyond that, there is no significant difference in the time in range outcomes between hybrid closed loop and standard insulin therapy. Again, though, if you look at what happened to the glucose during a standardized day, there is separation overnight, but even more markedly, the day times look very much the same as they did, same in the standard care group and in the hybrid closed loop group. So any separation really gets lost. So again, looking at those maternofetal outcomes, there were more neonatal intensive care unit admissions in the hybrid closed loop group, no difference in NICU length of stay, and a small reduction in large for gestational age, which presumably reflects a non-statistically significant overall reduction in glucose exposure overnight, certainly. And again, when we look at the incidence of severe hypoglycemia, it's slightly higher in the advanced hybrid closed loop therapy group compared to standard, which reflects the ADAPT group. So again, there's no apparent impact on severe hypoglycemia, there's fewer hospitalizations for severe hypoglycemia, but it failed the primary outcome of time in target. There was increased treatment satisfaction with hybrid closed loop, but again, the cost effectiveness is not known. So these data are not as impactful as the concept data. This is a UK specific slide, really, but for context, at the moment, only one system in the UK, and actually, I think worldwide, is licensed for pregnancy affected by type 1 diabetes, and that's the Cambridge system, the CAMAPS. It's important to consider those pregnancy targets and the system glucose target. And the reason why the women in the Cristal study, that second study with 780G, the reason why it was essentially a negative study is because the women had such fantastic overall glucose at baseline. It's very difficult to improve when your glucose is very close to target at the start. But I think it's clear that hybrid closed loop is not a magic bullet, and it requires significant input and expertise from women with diabetes, along with the multidisciplinary team supporting them. And the other thing that we now don't know is how we measure, how we best manage and support women through the peripartum period. So how do we manage labour, cesarean section, spontaneous vaginal delivery, and how do we manage that immediate postpartum period and transition to not being pregnant and breastfeeding or not? So what about type 2 diabetes in pregnancy? Well, there's very few studies of technologies in type 2 diabetes affected by pregnancy, and this is, I think, reflects the overall technology evidence base that we have, but I think it's a surprising omission, and it's really surprising when you think that the incidence of young onset type 2 diabetes is rising more rapidly than any other incidence of diabetes, and we're going to see an entire population of young women living with type 2 diabetes who are in their reproductive age, and we're going to see young onset type 2 with pregnancies that are complicated, and we really do need to get that evidence base. These are real world data from the same period that I showed you earlier, 2021 to 2023. They're small numbers and they will inevitably be a highly selected population, but these are women with type 2 diabetes, pre-gestational type 2 diabetes, and tells you about the women on CGM and not on CGM. And actually the women on CGM have fewer women had an HbA1c in early pregnancy in target and in late pregnancy in target. Roughly the same number of babies that delivered were admitted to neonatal care, more preterm and more large for gestational age babies on CGM. But as I say, these are really small numbers, and I think these are biased by selection of women accessing CGM in pregnancy with type 2 diabetes, as it probably reflects a secondary complication or something else that was challenging about managing and supporting their diabetes through pregnancy. Hopefully, we will soon have data from this study, the PROTECT study, which is again being led by Helen Murphy, a randomized controlled trial of continuous glucose monitoring in pregnancy complicated by type 2 diabetes. Very similar in study design to concept in terms of the technology, the target, the randomization, and the outcomes measured. And we will hopefully have data from that soon, because that will potentially change practice. And the other thing that we have, we're very fortunate to have in London, is we do have the opportunity now to use continuous glucose sensors for people living with type 2 diabetes. And one of the things that we're able to do, if you look on the left there at the bottom, weight under criteria, we're able to give people living with type 2 diabetes who are pregnant and require an alternative to blood glucose monitoring to achieve their target glycemia, we're able to give them continuous glucose monitoring. And that's fantastic in terms of the large numbers of women with pre-gestational type 2 diabetes in London. Glycemic targets are almost routinely not achieved, so all of those women can access CGM. There is then a question about what happens after pregnancy, and how do we manage the taking people off technologies, but that's something to deal with once you've safely delivered a healthy baby. So in summary, continuous glucose monitoring is safe, effective and cost saving for women with type 1 diabetes in pregnancy as a standalone intervention. Continuous glucose monitoring may be most effective with multiple dose injection regimens and open loop insulin pump therapy. Because the outcomes were worse than closed loop and the outcomes were worse than MDI, open loop insulin pump therapy is not indicated in pregnancy. Women with type 1 diabetes and impaired awareness of hypoglycemia remain at risk of severe hypoglycemia in pregnancy, and that's important to remember, particularly with the reduced targets. And the real world data remains suboptimal despite implementation of continuous monitoring. But are hopefully improving, and hybrid closed loop does improve glycemia marginally and incrementally, and the cost effectiveness and the impact on adverse maternofetal outcomes is at best small. So I also promised that I would talk to you about GDM and continuous glucose monitoring in pregnancy. And the reason it isn't in the slides is because up until very recently, there was very little to say about it, and there was very little of an evidence base. There's a set of consensus guidance that I think will be published very soon. May even be launched next week at EASD. Actually, now I think about it, that will say that CGM is not indicated in pregnancy affected by GDM. And if we think about GDM and how we manage it, I think that makes some sense because very often women are on therapies that can't be changed. So unlike insulin, it can be difficult to titrate a therapy for GDM. But I think for women who are insulin treated with gestational diabetes, I think it is sensible to consider continuous glucose monitoring. And very recently, the Digest study was published, which does suggest actually that in insulin treated gestational diabetes, time in range is improved with the use of real-time continuous glucose monitoring. So we are hopefully moving from an evidence-free zone there, where consensus guidance will inevitably go with the sort of the do nothing option, which is to remain on self-monitored blood glucose. I think we'll hopefully move from that to a scenario where we can start to use continuous glucose monitoring for women with gestational diabetes, particularly those who are insulin treated, and particularly for those who are unable to achieve their target glucose. Thank you.
Thank you so much for that very insightful and comprehensive talk, Professor Nick. And also particularly thankful that you addressed this, entire bit about GDM also, because I think from the Indian perspective also, GDM and use of CGM is very important for us to understand, because we are a self-pay market, and we will discuss it through the panel discussion also. But it becomes a little difficult and iffy because not all gynecologists also will accept CGM recommendations in GDM, even when the patients are on insulin. So thank you for throwing some light on that. And would you be able to stay on the entire webinar? Excellent. So welcome to the panel discussion, and let me quickly introduce our three experts who are joining in. And before that, let me also welcome Dr. Banshi Sabu sir, who's our founding president of DTech, and also Dr. Rakesh Parikh, who's our founding member of DTech. So, and all our three experts, Dr. Jaiprakash Sai, Dr. Bharat Sabu, and Dr. Om Lakhani, all are here. So it's an all house now. Dr. Banshi, sir?
Yes, I am very much there.
Okay, we were actually waiting for you.
All well. Busy?
Sort of.
No. Sorry.
Great. So welcome. And we just had a wonderful talk by Professor Nick, and I know you were there.
So, Purvi, it was really wonderful. I mean, the insightful talk. And today we have very expert panel from all India, Bharat, Om Lakhani, and Jaiprakash Sai. And we will have a lot of discussion. And first of all, I should thank you, first of all. That's very important because you are the one who was behind this webinar, and many of the doctors across the country who are listening. Our purpose of doing DTech webinar is, as users of technology in our country are underutilized, we want more and more person to use it. So I'm sure this webinar, where many of doctors who are joining from all across the country, and they will also would like to join DTechCon this year in Mumbai. So that's again our purpose. And with this, we will have more discussion.
Sure. Let me
Thank you.
Thank you, sir, for those very encouraging words. We love to open with your, comments on DTech and the entire endeavor of DTech dialogues. So today we missed you, but thank you for joining in even now. So for our panel, we have Dr. Jaiprakash Sai, sir. He is a consultant diabetologist at Apollo Sugar at Hyderabad. He's also an honorary physician at the Austrian Consulate, visiting consultant at the TTD Temple, Tirumala, and has had very important roles, including been an advisor on the cabinet rank, Swachh Bharat Mission, Government of AP, and lots of awards, honors, and also international paper publications. Welcome, sir. We also have with us Dr. Om Lakhani, who's a senior endocrinologist from Zydus Hospital, Ahmedabad, founder of Mellitus Healthcare LLP and technocrinology.com. And of course, his areas of interest, and that's why he's here, have been very well focused in technology in endocrinology, thyroid disorders, and endocrine oncology. He's again has had a shining academic career with lots of awards and publications. Welcome, Dr. Om.
Thank you so much. Thank you.
And we have another veteran, I should say, not by age, but by his presence in DTech Dialogues, and very much an integral part of DTech is Dr. Bharat Sabu, who's a senior diabetologist from the city of Indore, physician and diabetologist. He has so many different facets to his career, including being an best-selling author and director at Prayas Diabetes Care Center, Indore, and co-founder of Doc Yantra Private Limited. He's had several accolades and recently also been part of the Madhya Pradesh state sort of drive on screening, one of the landmark endeavors. So congratulations on that as well.
Thank you.
Great. So with this illustrious panel, I think we can start some questions. I don't want to waste your time. I just want all that we want to pick on your brains as quickly as we can get. Okay, so Professor Nick, I just we talked about all the evidence and some of the lack of it as well. But what are your thoughts on the accuracy of CGM in pregnancy?
That's a good question. I don't think we have any concerns that the accuracy is significantly changed by pregnancy. There are lots of fluid shifts, and obviously, if you wear your sensor in the anterior abdominal wall, there are significant changes physically to that. But there's nothing from the data that suggests that the accuracy changes sufficiently to have a bearing on any of our clinical outcomes. So accuracy is different every day, isn't it? And with every sensor, it's a dynamic construct, and is not fixed. And some sensors seem to work very well and some don't. But I've not seen any challenges with sensor use in pregnancy, and I've not seen any data from any accuracy studies that would make me concerned that using it in pregnancy would be different. I guess the only thing to say is if you're going to rely on it for glucose management during a very sick, if a woman's very sick, then you might have a different view. We did a short study of variable rate insulin infusions informed by continuous glucose monitoring, and actually compared to capillary blood glucose testing, we wouldn't have made any different insulin decisions if we'd gone by the CGM data. So I'm reassured, certainly from the data we have so far, that there are no accuracy concerns.
Fantastic. I think that's reassuring. And I would like to ask, Dr. Bharat or Dr. Om or even Dr. Sai, any experience to be shared here, or do you feel different? Or I think we in the Indian scenario are also very comfortable with that, because
Dr.
we do
Purvi.
have extremes of temperature in certain places.
Dr. Purvi, can I ask one question to the faculty?
Of course, you
Professor
have
Nick,
the expert's privilege.
yeah. Professor Nick, it's a very excellent presentation. Are we treating very aggressively in treating pregnancy? Because the time below range, is it related to, because most of the studies we have seen that the outcome is not great with closed loop or insulin pump therapies versus standard care of therapy. So are we over treating pregnancy? Is it causing the outcome? Or maybe we are causing more hypoglycemic events, or aggressive treating pregnancy is causing the outcomes? Any thoughts on that?
Yeah, I think you're absolutely right. All type 1 diabetes, in fact, all insulin treated diabetes is walking a tightrope, and you can fall off your tightrope one side and fall into hypoglycemia, or you can fall off your tightrope the other side into hyperglycemia. And everyone who self-manages with insulin is trying to stay on that tightrope. What we do in pregnancy is we make the tightrope much narrower, and we make it much easier to fall one way rather than the other way. So, but the problem, I guess, in that is that the risks are much higher on both sides. So the risk of hyperglycemia is losing a pregnancy, or significant anomaly, or neonatal mortality or maternal mortality. So I think you're right that we do push very hard. And inevitably, when you're pushing very hard at a population level, you will have greater exposure to hypoglycemia. And there will, sadly, be maternal mortality from hypoglycemia as well if you have a large enough population. But these things are always measured on a population level. If you can make that tightrope a bit narrower and bias it towards that slight hypoglycemia risk, you have more healthy babies. And that is the calculation that ends up being made. But you're absolutely right. I've spent years doing clinical research to try to prevent hypoglycemia, and then in pregnancy we tell women that you can sit with a glucose of 3.5 for 24 hours a day, which in type 1 diabetes we would never do. So I think there are some tensions there, and the tensions are for the women as well, because we give them this finite set of messaging that don't worry about hypos, run in the high 60s, you're fine, we're not worried about it, keep going, have some insulin, correct down to a lower value, correct if you're 120. I think we're much more aggressive in a way that does engender risk, but we're trying to get a healthy mum and a healthy baby.
Nick, I just want to make one comment here, Purvi.
Yes,
That
sir.
time in range, it does not mean that you keep around 63 only. It means the percent time below range you have to consider when it goes less than 63 in a hyperglycemia and pregnancy. So we can always keep around, if you are not comfortable to keep or not, you don't want to keep very tight control, maybe 80 to 120 for most of your patients who are either type 1 or first time detected hyperglycemia and pregnancy, or they are 2 GDM, or they are pre-gestational diabetes. I mean, need not to fasting sugar around 63. If you are comfortable to keep them around 75, 80 or 85, that is what most of the time we try to do it, keeping fasting less than 90. We may not go less than 70, but what's the point is in time in range that you have not to worry if their time in range between 63 to 140, more than 70% of the time you should achieve. That's what you should try, or more than 90%, that whatever best if you can do if someone is pre-gestational diabetes or first time detected hyperglycemia in pregnancy. I agree with Nick that yes, should not be very aggressive in keeping there in a hypoglycemia, but most of us, I believe that most of us, if we are using continuous glucose monitoring, we would not be very happy to keep their sugar less than 70, maybe around 75 or 80 fasting, or most of the time in night time, and in daytime around 140, 130. That is what we try to do.
I think that's well said, but at least for type 1 we have, and pregnancy we have some metrics to follow. For type 2 and the CGM metrics, we don't have any complete recommendation as yet. So more is better, but what is exactly that cutoff? So I would invite comments from all of you.
Well, we do have studies in GDM and type 2 as well. There's one study which I remember, it's called Flamingo study, which looked at, it's a small number, so the numbers are small compared to type 1. There is a study called
That's been
Flamingo.
one of the other limitations that most of the pregnancy studies, except all the bigger studies that have actually, shown us whether we should treat and what should be the cutoffs as per the glucose meters, have been large. But with the CGMs, the studies have been very small with the.
Right. So the numbers have been less, but
Yes.
there was a study, just like, you had concept trial with type 1, there was a Flamingo study with GDM, which looked at the outcomes, in this population again, and they too had a similar result in terms of the large gestational age, for patients who were on the CGM. So we do have emerging data. There was a study called GLAM study, which actually did a sort of a normative data in pregnant women. They're just asked to wear CGM at different trimesters, and a normative data was obtained from them. These are normal women who don't have either GDM or diabetes of any type. So we do have some beginnings to these kind of concepts. I'm sure in future, again, I think these are type 1 is actually complex. Probably GDM and type 2 in pregnancy are more like low hanging fruits. Only probably, you'll have to find type 2 in pregnancy, but these days, that is also not very difficult to find these women. So I think, not very difficult to pull up the numbers. But I guess, as far as type 1 is concerned, it has probably the highest amount of benefits you get, with the use of CGM. In other cases, could probably do well with the, your conventional treatment as well. So that's what I think. But there is now emerging data in both these groups also.
Okay. So if we do use, CGM in pregnancy, especially in our self-pay market where patients can afford, what do you feel about the frequency with which we should use it? Dr. Bharat?
Ideally, we should use it all the time. That is the ideal scenario. But intermittent one is what I personally use due to that cost matrix only. But that is not sufficient, because pregnancy is a dynamic physiological thing and it keeps on changing. With every trimester, the body's physiology changes, the hormonal milieu changes, the glucose insulin interplay changes, and that is why I always recommend to a girl, if they can afford a CGM continuously, nothing like it, because it definitely improves the glycemic metrics and outcomes. We know this. It definitely improves. The only cost, as you clearly said while asking the question, is cost. If the cost is not a barrier, it is an ideal choice, and Om will agree to it. I would like to have your comments, Om, because you sit in a setup where more people come who are more friendly to CGM than my setup. What is your view on this?
Yeah, I mean, that theoretically, yes, practically, no. So, but I agree with it. I mean, if you can afford it, I mean, why not? If you have diabetes of any form in
Yes.
pregnancy, why not use? Anyways, you are compelled to do fingers like glucose, right? So, obviously, CGM is much more convenient. You'll get much more information, much more insights. But I think the best part is you have now data to show that, just using CGM improves your outcome. What could be better than that, right? So I think, and even, probably cost also, maybe, if you could prevent a large for gestational age of one neonatal hypoglycemia, the cost of that, I mean, the cost and the pain associated with that is far, less than the cost of a CGM. So, if you can, why not? I mean, why not use it? I agree, why not use it throughout the pregnancy if you have type 1 or type 2 or, diagnosed with GDM later.
And to add to it, Om, I think if we can, who knows, we are preventing a future diabetic.
Yeah,
So
yeah. And also what I feel is that, there is, in Indian context, if you see, they are very particular about what to eat, what not to eat, those kind of things. There's a mother-in-law involved, there are other family members who have a lot of pressure to put on, in pregnancy. So I think, it does add that also value. If there is an insistence of eating certain food, and you're clearly showing on CGM that there is a clear spike, then probably you would avoid that in future, right? So that's these are indirect benefits also. So if you can afford it, I tell my patients, whenever they come, first time I tell them that there is an option of CGM. Would you like to use it? Once they start using it, trust me, Bharat, they actually find it very comfortable, and then they would probably use it throughout the pregnancy. So I generally see that once it's just that initial barrier, if they cross that barrier, then they are very happy to use it.
That's
Very
actually true, because most of the studies also have shown that even though it may have been difficult to actually show a difference between SMBG, between the group using SMBG and using SMBG with CGM, in terms of these hard outcomes, definitely the patient preference has always been to use CGM.
Yeah,
Um,
absolutely.
so I think,
And I mean, what I feel is, again, pregnancy, they're actually more open to doing things which is right? I mean, often,
incentive.
yeah. So there is more, I mean, they would probably do anything which is more comfortable, which is easier, even though, they have to spend money, because that even, in a sense, there is a limit to it. There's an end goal. There is a definite time period to the entire thing, that anyways, if I do have to use CGM, it's going to be for the next 2 months, 3 months, whatever, right? So they know that, what's the end goal in terms of the time. And in that sense, they are more ready to kind of accept, even pumps also, and we offer them pumps that, type 1 with pregnancy. We tell them that, pump could be a great idea, and they are happy to start, planning in that sense. So that the acceptance is better, I think, it is improving.
So, Professor Nick, just circling back, I know you already told us that you would not have concerns about accuracy of CGM in pregnancy. But do the physiological changes during pregnancy impact any of the calibrations as such?
Not that the data tell us. I don't think there is any reason why they would. I guess if you have severe or really significant edema towards the end of pregnancy, then potentially, but I've not seen that as a phenomenon. But I guess if you have really significant edema, you might think about that. But the data seem fine. I mean, I should also say that we don't really use sensors that need calibration. So if you don't look, you don't find, right? So maybe actually they're terrible, but we haven't looked, so we don't know. Yeah.
And one more question that I would like all of you to answer is, what are the targets to follow for pre-gestational diabetes and pregnancy? And then, specifically with type 1, I think we are quite clear as to what we should, but with type 2 and with, GDM, what I know more is better, but then again, even at the lower end, what is the guidance that we want to propose?
I guess it'll be same for, at end of the day, it's the hyperglycemia which you're correcting. The targets tend to remain same. As you said, the data is still limited. We don't know what would be the right, targets. So kind of would be still extrapolating from what we know from non-CGM studies as well, which kind of becomes quite congruent to what we do anyways with what we did with the concept study. So I think what I feel is that I would probably not, keep targets too different from, in fact, type 1 is more complicated in the sense that, there is an insulin involved. There are multiple doses of insulin. Patient is already probably having a bit of hypoglycemic unawareness. For a type 2 or a GDM on insulin, it is much simpler because, the other aspects are not that much of a problem, right? So in the sense, I'd probably keep the same targets because in absence of any data, it's probably a good safety margin would be to kind of extrapolate what we know from non-CGM data and use the same there. That is my belief, and that is what we follow also in terms of the targets which we set for the patient.
Dr. Bharat?
I second Om. There is nothing to differ. Basically, we follow the same protocol. We all actually, being clinicians and being learned clinicians, we follow what Om has said.
Purvi, can I get to ask a question, please?
Yes. Go
Okay,
ahead.
it's an open question, and anyone from Nick to Bharat to Om, anybody can take that. Any concerns or aspects of patients, especially pregnant women, overreacting to the readings?
Yes, yes,
Uh,
yes.
right. So Bharat is getting excited to answer this.
Every day I
Both,
face it, sir. Every day I face it. This is a very common scenario. They look at minute by minute readings, and then I need to counsel them. This is more than minute by minute reading. You need to follow the 70% rule. Don't be panicky. Don't look at yours, because a pregnant female is, I think, I'm sorry to say, but she's very free mentally from all the other affairs. So she's looking all the time at all the time at her device, and then she's seeing that the values are fluctuating. And every day this is, that is why, sorry, but I was laughing when you were asking that question, that how come this thing of my OPD has just come out to you, that this happens every day. The best thing is to assign them to an educator. We assign every patient to an educator, but that also helps little bit, not much. We need to counsel them a lot, but in the end, they feel definitely a little bit of anxiety due to that. I admit it.
I have had those instances where, when you by bedtime, when you're tracking it, and say at bedtime they're seeing sugars which are in the 100 range, which is pretty decent. But the conventional belief and thinking that if it's 100, by morning it's going to dip by another 30, 40 points. So let me start snacking and checking. So on your CGMs, you're then seeing tuck, 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 tuck dots where somebody has scanned regularly, and then they've reacted to it. So I just wanted to understand the best practices that you would do in your practices, that how to counsel on this and how to avoid this anxiety and fear of hypo that sets in. So, Bharat, thanks for the answer. If Nick or Om want to add to that, please go ahead.
Also, specifically to the fact that they are going to see that overnight lows, most of them, and the response to that.
Yeah, I think that vigilance of glucose and the feeling that you have to act on every glucose value that a CGM gives you is common inside and outside of pregnancy. But obviously, the motivation in pregnancy is that much greater, and that vigilance may be even more so. It and if you haven't used CGM before and you start CGM in pregnancy, you've suddenly got 200 values a day that you feel like you need to do something with. I think reassurance, as Bharat said, you don't have to hit the target every single number. Don't worry about it. 7 out of 10 is good. And take an action and sit on your hands and try to wait to see the result of that action before you take another action. Insulin stacks, but food stacks too, and you end up in these roller coasters of pendulum effect. So it's trying to reassure, be patient, and tell them that they don't need to act on every single number, and use the trend arrow. The trend arrow is your friend as much as the number itself. If the trend arrow has become flat, things are changing. Just sit on it, sit on your hands, go and do something else, and try not to think about it.
Great. How do we counsel them to, improve adherence, so to say, and just monitoring more?
Sorry, while you are asking that question, I would also want to ask the expert panels: is there a time you tell any of them in pregnancy, don't check? Don't do this now. So let's give it a break and let's not check. Any
Yeah, I
thought?
think essentially to prevent the burnout. When is it?
And then is it supported, Nick? And is the NHS giving it included there for pregnancy? Is it free for all pregnancy and diabetes?
Yes, essentially, if you live in London, there's some slight variation in type 2 pregnancy, but if you live in London and you're a woman with pre-existing pre-gestational diabetes type 1 or type 2, you can access CGM. Gestational diabetes at the moment doesn't, but that I'm sure will change in time. And particularly for women who are insulin treated, I think that's a very straightforward thing for us to do. As I said, the difficult thing then is what happens afterwards. We tend to give it for 1 year, but that obviously that means that if you start CGM at about 10 weeks gestation, you'll get to about 4 or 5 months of postpartum, and it's not exactly as if life's gone back to completely normal at 5 months postpartum. So we then have that issue of what do we do next? How do we transition back to something else? Or is there a way that we can continue CGM to enable women to self-manage for longer?
So, are there any studies particularly looking at the CGM use postpartum in those with type 2 diabetes and also GDM?
Not that I'm aware of.
No, but then, Nick, this gives a wonderful opportunity to any of us, especially since it is funded. Why don't we start looking, especially for the GDMs, or where you may have used just insulin or maybe metformin and some. What's really happening in the postpartum period? So if you're getting CGM data in the immediate postpartum period, it will be wonderful to document that data.
Yeah, I agree. I'll add it to my list.
Okay. Don't forget who your co-authors would be for that paper.
All of you, definitely, all of you.
Exactly.
Okay. So, Dr. Sai, are you there or have you logged off? I'm not able to see you. Okay, so I think for Dr. Om and Dr. Bharat, what can we do to make it more accessible, affordable, even have maybe insurance sort of, help us with these barriers of use of CGM in the first place? And that it's pan population. I don't think it's pertinent only to pregnancy, but some ideas around that.
Purvi ma'am, insurance is one thing because I don't think government will be able to support this because they have a lot of other things to support and they are even not able to support that also.
Even with the recent reduction in GST, I think it's not
It is a peanut thing. GST is. Second thing, what we can do is we can have we can have a version of CGM which is more Indianized, where the margins are less and the value is transferred back to the patient. So time will soon come. I see that we will have our own Indianized version of something which will help our patients, because I think it is need of the hour to give every eligible patient CGM, because CGM is the thing they need most now.
Yeah, I agree with Bharat. So I think it's the problem right now is monopoly. Not literal. There are other companies, but more of dominance of one company right now, which is eventually going to change, right? I think. I mean, if I see, maybe 5 years, 10 years down the line, you're going to see, CGM replacing the finger sticks anyway. So now with a lot of data, I think there were issues initial hurdles, which often got cleared. I think there's a big boost during COVID also, in terms of hospital, hyperglycemia CGM use. So I think the ground is pretty much clear. I think there'll be a lot of emerging players. And right now, you have hundreds of companies, thousands of companies making glucometers. They'll all transition into making CGM. So it's going to happen. Price will come down. We are in that early stage right now with a monopoly of a company. So I think probably, I mean, I agree with Bharat, don't get government involved. They only mess things up. They'll probably add, some layers to it, which will make it complicated for new players to enter, and which will make it even more difficult. So what I'd rather say is let the market do its job, and you will find solutions soon. I mean, recently in the DTech group itself, there was a discussion about CGM, and there are people who are saying that, if there's an Indian company, we are ready to, take 1,000 orders today, right? We are ready to kind of, fund it like a Kickstarter. So there is a lot of interest, and I'm sure some entrepreneur will pick this up. It's a challenge, but I'm sure the challenge is going to be eventually be taken care of. And again, any new CGM, there will be issues of right now with the other companies. There are concerns, at least concerns.
also, yes.
With the accuracy and the ease of use and the availability of sensors and service element of it. But I think eventually it will get ironed out soon. So I think even if we just sit on it, the problem will be solved on its own by the market. So that's what I feel.
And then to complete the list, do you see any physical problems with the CGM or the sensor itself? Are there more reactions during pregnancy, the skin reactions, the rashes? in your experience, any of you, have you seen a little more of that, or it's been fairly consistent with what we see in the non-pregnant state?
Personally, I haven't. I'm not sure if there's any data to that, but we're lucky not having had any major issues with any CGM that I remember. Again, when we started using early, we had that same concern about, overdiagnosing of hypoglycemias, like we said, overcorrection by patients, so on and so forth. But I think in a sense, we're lucky that we started with a a sort of retrospective CGM where we kind of battle tested all these things. And then we had the intermittent CGM. We actually used the LibrePro for long time before we had the intermittent scan or the real-time CGM in the market. So we were kind of used to a lot of things, understood a lot of issues dealing with that. And then once that intermittent CGM did come in the market, I think we are pretty much prepared. But we don't see, I mean, I have personally not seen any major complications, in any patients. We had non-pregnant patients, especially type 1s who had issues, probably with the adhesive, they had reactions. But pregnancy, luckily, we had not had. So I think it's a good thing. So, yeah.
Great. And so I think with that, I would like each of you to kind of give your last summary or take-home message for CGM and leveraging CGM use in pregnancy. And just before that, I think what I wanted to clarify for our audience was that you are recommending that if there is no issue of affordability or accessibility, then CGM should be encouraged to be used during pregnancy, irrespective of whether they are only on lifestyle changes or metformin alone or insulin. So I think that was one clarification I thought we should have. And with that, I think we can come to the summary. Yes, Dr. Bharat, did you want to say something else?
No, ma'am. I just want to add to it that whosoever is watching this, they should make sure that they should offer CGM as the first choice to any pregnant diabetic patients who is coming to their clinic. If the patient refuses, then it's patient's fault. You should not be at fault being a doctor.
Great. Yes, Dr. Om.
Yeah, I think my take home, would be interesting. There are a couple of studies which I saw, and I think Dr. Manoj picked up one element of it after pregnancy. But I think one important use case I see, and again, we'd love to see more data on that, is using CGM in early pregnancy to predict GDM. There's a study done about 100 patients in I think Japan. From what I know, which actually did that, and they had some markers which they could predict, development of gestational diabetes. In fact, CGM is a very easy tool to use in early pregnancy compared to other biomarkers. Even OGTTs are more complicated than CGM. You just slap it on and or have some service provider do that for the patient at home, and then you have a beautiful data set which you could work at and probably use for predicting future gestational diabetes. So I think using CGM as a tool for predicting gestational diabetes is a very, very interesting use case, which I'd like to see in the future. And the second thing, what Dr. Manoj said is, if you have post delivery, if you're continuing to use CGM, then I would really like to see that how does that translate to future risk of diabetes. That's something which again would be a very important metric, because in that case you could actually propose to your patients that you continue using CGM post delivery. And then, based on that, we'll be able to kind of give some sort of a prediction whether, there is a likelihood
Also,
of developing
doctor,
diabetes in future, which could be a very, important thing, a sort of a touch point for the patient to be counseled for better lifestyle measures. So I think that these are areas where, interesting areas where we should probably look at.
Right. Dr. Sai?
I think CGM is very important in pregnancy. I think more important is empowering the patient regarding their nutritional aspect, regarding change of their behavioral change towards nutrition. I think physical activity plus a regular follow-up with the physician is very important. Just using technology and keeping tight control is not that. I think empowering patient is very important.
Right.
A regular follow-up with the physician also is very.
Thank you. Thank you for that. Professor Nick, if you could summarize
Well, I think you've just had two comments that are so important. I am an advocate for technology in all forms of diabetes where there's an evidence base for it being clinically effective and cost effective and safe and acceptable. And I think we have a fantastic evidence base that continuous glucose sensors can do that through pregnancy, certainly in type 1, probably in all insulin treated diabetes. But I think that point that what we should be doing is using education support as our principal management is really important, and technology is only ever an adjunct to education and support. If you don't teach people with diabetes or support people with diabetes to manage those glucose trends and those glucose values and those glucose changes, then it's just reporting a number. It's not an intervention in itself. It's what you do with the number that is the intervention. So massive advocacy for CGM, but it's not something you can just give to people and expect them to use without any support. You need to support them to use it effectively.
I think all the tech companies really need that message. Great, great. So I think it was a very, very interesting session and very, I would say, very empowering to physicians and clinicians, because this is not a very well talked about area and not so commonly tackled with. So really appreciate your efforts, Professor Nick. I know it's actually the middle of the day for you. So thank you for being here and for bringing so much value to it. And of course, we would love to be the co-authors on your next publication, looking at the postpartum data. Just kidding. And a very big thank you to Dr. Om, Dr. Bharat, and Dr. Jaiprakash Sai as well, because I think for them also it's midweek in the middle of the evening, and all the Indian clinicians work till late. So thank you very much again for being here for DTech Dialogues. And we will reach out once again, on a later date to pick your brains some more on a related topic. And on behalf of all the DTech founders, that's Dr. Banshi Sabu sir, Dr. Jyoti Dev sir, Dr. Manoj, Dr. Rakesh, Dr. Amit, everyone, and Dr. Mithun Bhartia, of course. A very big thank you to all of you, and a big thank you to the audience for logging in as well. See you soon.
Thank you. Good night.
Good night.